Hi, and welcome to the third edition of Yale School of Public Health's COVID-19 Right Now. I'm James Hamblin. I'm a lecturer in the School of Public Health. I'm here joined today by Linda Niccolai, who's a professor of epidemiology of microbial diseases and also director of the Connecticut Emerging Infections Program at Yale. Today we're going to be speaking about the need for continued contact tracing, even when I'm here in New York and I've been told just not to get tested unless I need to go into the hospital. So it seems like there are a lot of cases out there that we're not picking up, but it's going to continue to be a cornerstone of the response going forward, and hopefully we'll catch up. And I'm very curious how that can be done and what that will look like and how that might influence lives here in New York, in Connecticut, and around the world. So there's no one better to answer that question than Dr. Niccolai. Thank you so much for joining us on the show.
Thank you. Thanks for having me.
Could you tell me what's at the front of your mind in terms of catching up and what needs to be done to get us to the place where we can do the contact tracing that ideally we would have been able to do all along?
Well, that's a great question. And even the framing of your question, I think, speaks volumes to where we are right now with contact tracing and where we may go with contact tracing. So the idea behind contact tracing, for people who may not be as familiar, it's really been an important public health activity in the control of infectious diseases for decades. And the idea is that when people have an infectious disease, if we can learn from those people diagnosed with the disease, who their contacts are, who they've been around in recent days, who may have been exposed to the infection, if we can notify those people that they've potentially been exposed, then they can do things to, first of all, take care of themselves. They can seek treatment or isolate themselves, or they can self-monitor for symptoms. But really the public health goal of this is that we can break these chains of infection and further spread in the community. So in normal times, we would do contact tracing. It's an activity that really would be done by local and state health departments. I think very early on in COVID-19, local health here in Connecticut and the state health department, as well as the university, Yale University, who wanted to do their own contact tracing for members of the Yale community, realized that the number of cases was just going to be too vast and that they would not have the capacity to do it. So we've gotten together a group of volunteers who, with a lot of support and guidance from city and state health departments, are doing contact tracing. So we're sort of at a funny time with contact tracing for COVID-19 because we really are, still here in Connecticut on the upside of the curve. And it's really, contact tracing ideally would be an activity that would try to get us ahead of the curve, but we're not ahead of this curve, right? We're on this curve. So we have mounted this response, and I can talk more about the details of that. But I think that, it's important. I think of this as a real long-term effort in the sense that when we turn the corner and we're on the downside of the epidemic curve is when contact tracing may be really important. Right now, people are largely socially distanced. We call a lot of people and they say, I haven't been anywhere in weeks. So the advice the guidance we're giving people is guidance that has been handed down from their employers, from the governor of our state, even at the federal level. So I think this idea of contact tracing will only increase in importance and be especially important when we do turn that corner and social distancing is relaxed and people do start to get back out into the community. We're going to need to be really vigilant about notifying people that they've potentially been exposed.
Right. Are you modeling your work off of any place that has had success? I think of South Korea as some place that, at least I've heard, was able to do contact tracing. And because we haven't seen this disease before, it's hard, I'm sure, to know exactly how to advise people and how the system should look. But without getting too into the weeds, is there something that has been advising how you're thinking about setting this up?
Yeah, well, yes and no. I think that there is a lot to be learned from places that have successfully, sort of turn that corner. Places like South Korea, China, other places. I think the thing about it is such a local activity that it's really hard to extrapolate from other places. So, for example, the work that we're doing now in Connecticut is a real partnership with the Yale University, the city of New Haven, and the state of Connecticut. And that's a unique setting, right? There's no place else that is like Connecticut. So I think that there are principles that contact tracing is important, that systems need to be set up, that they need to be sustainable, but it really needs to happen within the local context of how city and state governments function.
Sure. Well, so maybe a better way to frame it then is what is a good example of a disease that's where contact tracing in Connecticut has worked really well,
Mm-hmm.
and what's the textbook approach for
Mm-hmm.
how that should go? Then maybe we can turn to how this has, the
Yeah.
different unique challenges here.
Oh, yeah, there's a lot of unique challenges. So contact tracing works really well when we have testing and treatment for the disease. So take, for example, syphilis. So syphilis, back from the 1940s when penicillin became available for widespread use, the advent of testing for syphilis and penicillin for the treatment of syphilis really is what made contact tracing so useful. So I think of syphilis as just a great example of how contact tracing is supposed to work. So people who are diagnosed with syphilis can be asked about who their recent contacts are. Those are people who may be asymptomatic, but infected, and they may also be infectious. So if these people who know they've been exposed, they can go to, again, in a perfect world, they would go to the doctor before they had symptoms, they could be tested, they could be treated, and they could be cured. And that really ends that chain of transmission. So the people,
Right.
it's the idea of shortening the duration of infection, so preventing future exposures. Well, for COVID-19, I think everybody knows that we have very limited testing and unknown treatment. So the best advice we can give people right now is to monitor their symptoms and stay home. But again, people are supposed to be staying home anyway. So some days I really wonder, we're just calling people and saying, you've potentially been exposed, you should really self-isolate. And people say, we're doing that anyway. And we say, okay, thank you very much. And we get off the phone. So it's not quite working the way we would like it to be working. We'd like people to be able to get tested, and if they're infected, get treated. So we're not there yet. But again, that's why I think setting up this system will be really useful when testing is more available, hopefully in the near future.
Are you getting test results in a timely manner? I've heard from people who it's taking 5 or 6 days in some places. So, they're self-quarantining for that period anyway. But this requires a relatively rapid turnaround in order to be useful, right?
So I think that turnaround time is getting better.
Yeah.
There's a lot of different testing systems happening. There are private labs, there are public labs, there's drive-through testing. What I can say from our perspective, so COVID-19 is a reportable infection. It's a reportable disease. So when a laboratory test comes back and it's positive, that gets put into the state's electronic disease surveillance system. And once it's in the state electronic disease surveillance system, it's immediately available to us. And again, that's because of our partnerships with state and local health. So once there is a laboratory confirmed positive result, we know that pretty quickly. I mean, I have to say, I've been impressed actually at how quickly test results are ending up in the state database. And I think it's because people are taking this very seriously, and these lab reports are not lying around, in a folder. They're being immediately put into the database so that action can happen. So there are still some lags, but to the best of our ability, we're getting that information in pretty good time.
I had talked a while back in some of my reporting with Albert Coe about sensitivity of the test, and there were questions at the time, I know, just about exactly how sensitive it was. And I'd heard Dr. Fauci recommending 2 tests, and I know in China they were doing 2 before you could rule it out. How confident are you in a negative test and advising people that we're saying everyone should stay home now anyway, but when we are in a phase where this might advise whether or not a person can return to work or go out into society, do you think sensitivity of the test will be an issue with false negatives?
Well, that's a great question, and one that's a little bit out of my area. I think I would
Okay.
refer back to Albert Coe on the testing. What I can say in terms of contact tracing, what I think is going to be really important is, first of all, to ramp up the testing that we're currently doing. But this idea, we're starting to hear a lot now about antibody tests, and
Hmm.
wouldn't it be great if we had an antibody test? Because that's something, again, I'm optimistic we will eventually peak and start coming down and turn the corner. And when that happens, people, many of us have been exposed and don't know it and might be antibody positive. And that would be really useful information for people to have around return to work, return to school guidance. So the sensitivity of the test is a little bit out of my area, but in terms of contact tracing, I'm eagerly awaiting a readily available antibody test that can be used widely.
Yeah, it seems like if you had the antibody test in combination with the diagnostic test, you could be pretty confident that you could say something to someone. I have seen there's a study out of China yesterday that was not yet peer reviewed, but made headlines nonetheless. And so I'm, taking this information as it comes, but that some people might have the antibodies, but at a low level that might not confer immunity, which would throw another wrench in the gears here.
Right.
So it's, I don't envy your position of having to, it's an enormous challenge.
Yeah, we're definitely acting, we're acting with a lot of imperfect information and a huge amount of unknowns. But I will say that one of, I think, the ancillary benefits of this contact tracing program that we're doing is this community outreach. So we have these tests, and sometimes there's a lag and they may not have perfect sensitivity, but we're talking to members of the community. We're calling people who are self-isolating, they're staying at home. Everyone is unsettled and anxious about this. And I do think there is this added benefit of sort of providing this type of community outreach, talking to people, giving people a place where they can ask their questions, express their concerns, and feel like they're being heard and like somebody cares. So the science is not perfect in this world, but I do think there's that added benefit of the community outreach piece of this.
Yeah. It's something that comes up in the past when I've talked about contact tracing is people's privacy interests. So how is that handled in terms of, I guess, syphilis, and is there anything different with COVID-19? Whereas if I tested positive and I told you my recent contacts, how exactly they would be notified, what
So
they would know.
It's a fantastic question. So before COVID-19, most of my work was in other sexually transmitted infections like syphilis and gonorrhea, chlamydia. So I have spent a lot of time thinking about the privacy issues. So certainly for the sexually transmitted infections, the privacy issues are huge. Just because of the stigma, which is really unfortunate, but true. So I should say that this process is completely confidential. So when we are talking to a patient with COVID-19 and we ask them who their contacts are, and then we call the contacts, we don't say that we don't give the patient's name. So in theory, it's confidential. But what's interesting is most of the contacts we're learning about are household contacts. So because most people are staying home and not going to work, and they're not going to parties, and they're not going to, they're not socializing. So we still do not reveal anybody's name. But when we call up contacts and say, we've been told that someone in your household has been diagnosed with COVID-19, I think people can kind of figure that out. There's also not the same type of stigma around COVID-19 that there is around something like syphilis. So it is a confidential process. We never tell the contacts who the case patient is, but I think in most cases it's probably known.
Right. And how do you define a contact? Because I think, for me personally, the only contact I have is briefly with maybe a cashier at the grocery store, or someone at the pharmacy, or some of these few essential services.
Right.
And otherwise, there is no other contact. And there are obviously questions about transmissibility here and how long you have to be close to someone in order to be considered a contact. Where are you drawing that line now? And realizing this will change as we know.
It already has changed. So,
Okay.
there have been, so first of all, there's this question of how far back in time do we elicit contacts? So when we started doing this project, the guidance from CDC was to ask patients about their contacts since date of symptom onset. And then we realized there might be some asymptomatic transmission. So then the CDC guidance went to 48 hours before symptom onset. So we asked patients to think back the day you first had symptoms, go back in time 2 days, and tell us about your contacts. Some of the people we're working with now, they want to go back 3 days to be on this, to err on the side of caution. So what's a contact? It varies and it changes. In terms of, and there has been other guidance around. So at one point in time, I think the guidance was something like, and forgive me, I can't even remember all the details. It has changed so many times. I think it was something like, if you were within 6 feet of somebody for 10 minutes or more was something as a contact. So if you were, right, or were within 6 feet for 30 minutes or more, or if you were within, so we are not being very rigid about what's a contact, because again, that definition has changed and we really don't know what the actual contact needs to be for transmission to occur. We, as I mentioned, we're mostly getting household contacts. We are getting some workplace exposures. I mean, we are all supposed to be staying home, and those of us that can stay at home do stay at home, but some people are still going to work. So we are getting some workplace contacts, and then we're getting some more like what I would call casual contacts. Like, so for example, it might be like the manager in the apartment building where I live. So you're home, but maybe the manager came to your door. So we're really just, again, this is public health. This is not a perfect science. Our protocols are, I think, in flux, but we're really taking any contact that a patient wants to tell us about and doing notification to the best of our ability.
Right. I should add now that we're live on Facebook. There were some technical issues, but if anyone is watching and wants to ask questions, please put them in the comments and we'll get to them. We're talking about contact tracing right now and what constitutes a contact and how people are notified and how this will look in the future, how it could shape our lives and help create a strategic plan, right? Where we don't just have to tell everybody to stay home, where we can track things and be real strategic about who needs to stay home and who can go out. So yeah, if you have questions, let us know. I have read a little bit about other countries using iPhone tracking, using other data that would, I'd expect in the US, raise privacy concerns that would make that impossible or infeasible. How are you thinking about limits on personal privacy and during an emergency like this?
So that is an area of great interest to many people. The way we're currently doing contact tracing is, I would describe it as old school contact tracing. So we're interviewing patients on the phone, we're calling their contacts on the phone. There is interest from some people at Yale in doing more technologically advanced or savvy methods of contact tracing. So things like GPS tracking, mobile phone apps. I have a colleague on this project. His name is Tyler Shelby. He's an MD PhD student at Yale, and he has been instrumental in getting this program up and running. He's organized an amazing group of volunteers, and he's very interested in that. So I think the idea is, again, this is a public health emergency, and we've been largely focused on getting the work done. And I think once we sort of come out on the other side of this and have our systems in place, there's a lot of room for technological innovation. There are certainly going to be privacy issues, but I'm confident that people can work that out. There's a lot of interest in cell phone, mobile app tracking, GPS type things for contact tracing.
Yeah. Do you know offhand any of the contact tracing methods that were used in other countries that would just not be feasible here?
I don't know.
Okay. I don't want to quote because it's not my area of expertise, but I know some people were using iPhone data, and I know in parts of China, at least, there would be someone show up and say, we need to test you. So we have a question here from a viewer that came into us previously, and it's about it touches on the question of public distrust right now. People are hearing different messages from different levels of government, from media.
Mhm.
People have been told not to trust the media in very literal ways, and now at a time when we have to inform people of certain things, like that you should go get tested and report your contacts, and you can feel safe about doing that, and your privacy is not going to be breached. How does
Mhm.
trust in that communication help or hinder the work that you're attempting to do?
I think, well, it's another really good question. I think, issues of trust are, I also do a lot of work in vaccine hesitancy, and issues of trust there are really important. And I've sort of come to really believe that, I think people by nature sort of trust the experts, or they don't. And in this case, I feel like the experts are, the Centers for Disease Control and Prevention, local, state public health authorities, the scientific experts. And again, the experts are really people who do this work for a living, right? They're not people who all of a sudden are entered into this field, but I think people who were trained in an area and who their professional career is devoted to an area, those are the experts. So I just want to encourage people to listen to the government, to listen to the experts, and the media is a wonderful conduit for getting that information to the public. I just think people need to think about what the source of that information is. But I think it'll be interesting to see sort of the long-term effects of trust in general in society. Again, thinking about vaccine hesitancy and issues of trust there, and COVID-19 and issues of trust here. And that's an important question.
Well, I think I've exhausted my questions, and I haven't. We're late and get going live, but is there anything else that you wanted to address, or that's at the front of your mind right now about contact tracing or otherwise?
Yeah, well, again, I think, we're in this for the long haul. I think COVID-19, we will come down the other side of the curve, but this will be an infection and a disease that will be with us. It's not going to go away. And I think that, people are starting to talk about things like a second peak or a third peak. So this will be the first peak and sort of the future peaks. And also the fact that there will probably always be some low level, or hopefully low level amount of community transmission. So the role of contact tracing will really be, once we get over this first peak and stabilize at some level of transmission, like we do for most infectious diseases, I think contact tracing will be really important to get ahead of those next curves. So when we see signals or when we see resurgences, we can really, identify hotspots quickly and put them out. So hopefully going forward, we will really be able to get ahead of future waves of this pandemic. And contact tracing will be a really important part of that. I think some of the innovative methods you talked about earlier, doing real-time contact. One of the problems with contact tracing is it requires the patients to go back in time and think about their exposures, who they've been around for the past 14 days. If there was some way, and again, this is the idea that Tyler Shelby has, the colleague I'm working with on this, there was some way for people to, in real time, be recording their contacts so that the very moment they're diagnosed, there's a list of contacts, it's readily available, it doesn't depend on recall bias, it doesn't depend on any of that. So if there were ways, and again, that's a really sort of proactive way to get ahead of it. So I think that once we, right now we're really just struggling to get on top of the contacts for the patients that have already been diagnosed, but going forward, there's a tremendous amount of opportunity for innovation that could really be effective. I'd like to see this epidemic curve go down and stay down, and not for there to be, future waves or additional peaks. So contact tracing, testing, the testing will be critical, and in combination with that, the contact tracing.
Right. So it sounds like you're establishing the infrastructure and the methodology here that will be ready for a robust system once we have all that technology. in
Yeah, I think
place?
I do. I think it's the infrastructure and the systems. But again, hopefully those will evolve and become more efficient and more modern. And we won't be doing everything by telephone and on paper going forward. I think the really important thing that we're doing now is really developing the partnerships. So this has been a very complex endeavor. It has involved Yale University, Yale Health Plan, city, local health, City of New Haven, Department of Public Health in Hartford. It's involved, the 3 health professional schools at Yale, public health, medicine, and nursing, and over 130 volunteers. And I think really what we've done now is we've developed the partnerships and the relationships that we all now know each other. We have a very fragmented healthcare delivery system in this country. I'm sure I don't need to tell you that. For example, in Connecticut, we don't have county health departments. All health in Connecticut is done at the local level. So being able to communicate across these different jurisdictions is really important. So I think really what we've done is we've made a lot of connections, developed a lot of partnerships, and really gotten all the players to come together. And I think that's been incredibly valuable.
Yeah. I'm sure it will be as this plays out over months and potentially years. We do have one question from a viewer. So before we wrap, do you have time to take that?
Sure.
Okay.
Yeah, sure.
So it says, do you imagine that the goal will be to be able to test everyone to find out who ever had COVID-19 and had been asymptomatic and never knew they had it, and possibly passed it to someone who had symptoms? I think we addressed this a little bit earlier with the serology testing, but do you think that maybe that would inform your work if once there is antibody testing, if we just recommend everyone gets it so we have a baseline knowledge of who's immune and who's not?
Yeah, it's a great question. And again, that's a question I would leave to people who work in that area. What I can say is that once there is an antibody test and people are, one idea is that we could use that antibody test to loosen some of the social distancing restrictions. So if you're antibody positive, maybe you go back to work. So once that happens, again, I'm not going to make recommendations on who should be tested and who shouldn't be tested. That's out of my area. But eventually that will happen. And that's what I think the role for contact tracing is going to be, to make sure that once people do go back to work and back to school and the social distancing is relaxed, perhaps because of serology tests. But to your point, positive serology, we aren't going to necessarily know what degree of immunity that confers. So I think we all want to get back to work and back to school and back out in the communities, and contact tracing can help to make sure that we all stay safe when that happens.
Yeah. Okay. Well, thank you so much for all your time and for the work you're doing. And I hope you're getting some rest and sleep in between all of this, because it's an enormous task, but thank you for your work.
Sure. Well, thanks for the time. And if there are, so I believe this is being broadcast to some Yale alums. So if any of my former students are out there, I just want to say hi, and I'd love to hear from any and all of you. It would be a bright light in my email inbox.
That's great. Well, thank you so much. And thank you to everyone for watching, and we'll be back next week.
Okay.
Bye.
Thanks.